अनम्यूट करना है।
हाँ अभी अनम्यूट हो रहा है।
इतनी छोटी छोटी बातें हो जाती है।
Rupaji, can you see Dr. Felicia? Chitra?
Krish, can you announce once if by chance ma'am has logged in from some other profile name or display name? Because with this name she is not available. Can I have her number?
to the end. A warm evening to one and all present over here. Let me first of all salute to our brave colleagues who are in the frontline battle with COVID-19 around the globe. On behalf of CNRS and our nursing fraternity, we pay tribute to frontline COVID-19 warriors who are fighting the nationwide public health crisis, and special tribute to those who lost their lives for selfless services they are provided. The galaxy of intellectuals, invited guests, academicians, nurse educators, nurse scientists, nurse managers, nursing officers, budding nurses, and my dear friends. It's a great pleasure to have delegates like you coming from various states and exhibiting your interest and involvement in this online gathering. I am Mr. Chris Thomas, Secretary of Clinical Nursing Research Society and Assistant Professor in Psychiatric Nursing, Mount Abu, Rajasthan. On behalf of CNRS, welcome you all on this online gathering. Clinical Nursing Research Society, it's a society which is established in the year 2019 under the able and efficient leadership of Madam Mrs. Uma Anta, Dr. Suvash Khanna, and Mrs. Shashi Bala. CNRS is founded with aim to bridge the existing gap of clinical and research in nursing and to promote and percolate evidence-based practice in day-to-day clinical nursing. Evidence-based practice is the first step towards the leading position of nurses as clinical health professionals, administrators, and policymakers. Clinical Nursing Research Society has planned to have a series of online activities such as webinars, panel discussions, lectures, training, online courses, etc. during these crucial times of COVID-19 to create a platform for insightful interaction with eminent nursing personalities to share their experience, thoughts, and valuable guidance on various aspects of nursing and healthcare to nurses. It has organized its first webinar on International Nurses Day theme on 16th May, and which was really successful in terms of its organization, coordination, participation, and deliberation. We are extremely overwhelmed with the response of our last webinar. CNRS is happy to share that we are signed MOU with ECO India, a non-profit organization who serves as the operating system for healthcare in India that is fully integrated into public health system, who had facilitated our live webinar, and we are so privileged to host it with the collaboration of ECO India. We have already launched Nursing Now program and Nightingale Challenge also. Here today, we have come up with our second live webinar, which is themed on clinical audit and EBP for quality improvement in nursing, call for action. Every day in the nursing practice settings, nurses encounter questions, problems, and patient needs that require effective clinical decision-making for appropriate intervention. A call for greater effectiveness required healthcare providers to enhance their knowledge and skills by incorporating research-based evidence into clinical decision-making instead of relying on only what they already knew or had seen others doing. I hope this webinar will definitely bring out some strategies to implement evidence-based practice in daily practices and able to differentiate evidence-based practice, research, and quality improvement. Before moving to our session, I would like to give you some instruction. If you have any questions during this webinar, please write your questions in the chat box. At the end of the session, the questions will be answered by our eminent speakers. Our first session is on clinical audit and quality improvement program in nursing. Clinical audit, it's a part of continuous quality improvement process. It consists in measuring a clinical outcome or process against well-defined standards established using the principles of evidence-based nursing. If you think you can win, you can win. Faith is necessary to victory. It's a matter of pride and joy to all of us. We have an inspiring lady who is our first guest speaker, a person who made all of our nursing fraternity proud by her distinguished work in numerous capacities, Mrs. Bobby Ramesh, who is a principal assessor for NABH, quality nursing graduate for prestigious Armed Forces Medical College, Pune, having 24 years of clinical, teaching and administrative domains of nursing apart from quality in healthcare. She has proven a record of reliability and responsibility in numerous capacities. Director of Nursing Service, India Operation Division, Parkway Pantai Limited, Director of Nursing Service of Apollo Hospital, Hyderabad region, and Director of Nursing Service in Cheslock Hospital. She served as Principal at St. Thomas School of Nursing, Chamaracheri, and she's a determined personality, which I would say for this session, there could not have been a more appropriate person than her to embellish, to enhance, to enliven, to enrich us. So may I call Madam Mrs. Bobby Ramesh to carry the session on clinical audit and quality improvement in program in nursing. Hand over to you, ma'am.
Thank you so much. Thank you so much, Chris, for the wonderful introduction and the introduction of myself and of this session. And I'd like to thank Mrs. Uma Handa, ma'am, and the organizers of Clinical Nursing Research Society for giving me this opportunity. And thank you all so much. And I'd like to thank all the participants for joining us on a Saturday evening. Today's topic of the webinar is clinical audit and evidence-based practice for quality improvement in nursing. And I'm going to speak on clinical audit for quality improvement nursing. Just a minute, I want to share my slides. Your voice. The slide is visible.
Yes, ma'am, it is visible.
Yeah. So Hugh Brendan Devlin, who was a surgeon, the first founder director of surgical epidemiology from Royal College of Surgeons, England, he said, surgery without audit is like playing cricket without keeping score. And he was a pioneer for surgical audits. Now, coming to clinical audits, I do not know how many of all the participant knows, but Florence Nightingale was one of the pioneers of clinical audit. She was a qualified statistician and a good mathematician as well. During the Crimean War in 1854, she noticed that most of the wounded soldiers were dying not only because of the battle wounds, but also because of infections and because of poor sanitary conditions. So she made a detailed report. She and a team of nurses started collecting the data of the mortality rate, and she improved the sanitary conditions and the infection control practices. And the next year, she proved that with improving the sanitary conditions and infection control practices, the mortality rate could be brought down from 40% to 2%. So the reports which she has published at that time is still available. You all can Google search and see that report. So wonderfully, she has made this report and statistics on this audit on mortality rate of soldiers and how it could be improved using infection control practices. So she is also one of the pioneer, apart from Donabadian, who was a physician who established this framework of structure, process, and outcome measurement for quality improvement in health. Now, in the healthcare, quality improvement has become a mandate across hospitals, especially in this 20th century and 21st century. It has become mandate. Previously, people were not so aware of clinical audits, but of late, it has become interesting topic, and people are curious to know, people are curious to implement in their hospitals. And NABH also has mandated, previously NABH has mandated 4 clinical audits for a hospital going in for accreditation, whereas now it is a mandate with the 5th edition. It is a mandate to do clinical audit by all departments. All clinical departments have to do mandate clinical audits. Now, why it is important in nursing? Because nurses are the key caregivers in the hospital. While the doctors are in command, it is the nurses who execute the care plan. So their role is paramount for influencing the quality of patient outcomes, quality of the treatment given, and also for patient satisfaction. Hence, hospitals' pursuit of high quality patient care is dependent, at least in part, on their ability to engage and use the nursing resources effectively. Coming to nursing audit refers to assessment of the quality of clinical nursing. There are numerous benefits, just to name a few. It evaluates the nursing care given, it helps improve the quality of nursing care, and it's a stimulant to better records. Nursing audits aid in identifying the training needs and also helps in continuing education. By doing nursing audits, we can use the resources and the skills efficiently. Nursing audits and the data collected will contribute to research as well. Nursing audits can be done by two methods, or there are two types of nursing audits: retrospective audit and concurrent audit. Retrospective audit is evaluating the quality of care by examining the nursing care as it is reflected in the patient care records after it has been completed. And concurrent audit is evaluating the care when it is being done using a predetermined criteria, interviewing the staff responsible for the care, and also reviewing the patient's care plan and other records. So coming to the definition of clinical audit, this definition is taken from NICE guidelines. Clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and the implementation of change. Aspects of the structure, process, and outcomes of care are selected and systematically evaluated against the explicit criteria. Where indicated, changes are implemented at an individual, team, or service level, and further monitoring is used to confirm improvement in healthcare. So before we learn about clinical audit, we should also know the difference between clinical audit and research, clinical audit and quality improvement program, clinical audit and medical audit. So that helps us identifying audit topics appropriately for clinical audits. So clinical audit determines whether the right thing is being done, whereas research discovers the right thing to do. In clinical audit, it compares actual performance against standard, whereas research identifies the best approach and thus the set of standards. Clinical audit is conducted by the service providers, whereas research is conducted by researchers. Clinical audit never involves experiment on patients or healthy volunteers, whereas research may involve experiment on patients or healthy volunteers. Clinical audit does not involve investigation of new treatment, whereas research involves comparators between new treatment. In clinical audit, it requires only basic statistical analysis, whereas in research, detailed statistical analysis is required. Ethical consent, not normally required, but for research, ethical consent is a must. When it comes to quality improvement project, clinical audit is quality improvement projects, because many have this doubt of whether clinical audit and quality improvement project are the same. It is not the same. There is a slight difference. Ideally, clinical audit is also a quality improvement project or a quality improvement program. It's part of quality improvement program. But in clinical audit, these audits are measured at fixed intervals and the gap may be long. Whereas in quality improvement program, it's a continual measurement using a PDCA cycle, and the re-audits will be more frequent, even on a weekly, daily basis. Whereas in clinical audit, we do it on a monthly, quarterly, half-yearly basis after implementing the changes. Clinical audit has to be based on standards and guidelines, based on evidence-based practices, and from good literature. Whereas for quality improvement project, it is not necessarily required that it should be based on standards. You can have a internal target as well. All clinical audits are QIPs, whereas all QIPs are not clinical audits, because for QIP, not only clinical issues you can take other issues such as improving your patient satisfaction. You can take reduction of nursing attrition, audit, quality improvement project for reducing the nursing attrition, which is a burning concern these days. So all those topic, non-clinical topic also can be taken for quality improvement project. So clinical audits will be part of quality improvement program and project, whereas all quality improvement projects will not be clinical audits. Now coming to medical audits, clinical audits is not synonymous with medical audit, because medical audit is peer review of evaluation of medical care through retrospective and concurrent analysis of medical record. It aims to improve the quality of healthcare services rendered by doctors to patient, and that is called medical audit. Whereas clinical audit is usually multidisciplinary. Even when we talk about clinical audit in nursing, nurses alone should not be doing that. It should be by a multidisciplinary team, and you should choose topics wherein a multidisciplinary team should be involved, wherein the aspects of structure, process, and outcomes of care are selected and evaluated against the explicit criteria. Now, clinical audit has to follow this cycle. First, you identify the problem and make your topic, you prepare your topic based on the problem, and then you have to define the standard or criteria which has to be specific and logical based on various international or national guidelines like NICE, ISMP for medication errors, like that. There are so many good guidelines available. So based on those guidelines, you can define the standard. Then you have to collect this data. You have to have a specific methodology and sampling for collecting the data, after which you have to do a detailed analysis of the data collected. Based on the findings, you have to find areas of improvement and plan of action for improving by implementing various changes. After that, after a particular interval, you need to do the re-audit after implementing those changes. So the cycle continues till you achieve the desired standard or desired targets. So the audit doesn't stop once you make your findings and then you propose the changes. It doesn't end there. The audit cycle continues till you achieve the desired target. For doing the clinical audit, for various types of samplings are there: simple random sampling, systematic random sampling, consecutive sampling, stratified. Various sampling techniques are there, and we have to use appropriate sampling. In the hospitals for our clinical audits, normally we use a systematic random sampling, but we have to ensure that this sampling should be the data which is representative of the population being audited. Sampling also helps in reducing the workload of the staff, but we have to see that probability of bias also has to be considered. Now, NABH has given in their 4th edition annexure the sample size based on the population size, based on statistical principles, which is available on NABH site also and in NABH books. And so when we take a sample, the sample must be adequate. So for 50 or 100 or 1,000 population, whatever sample size is supposed to be taken, it is given on this side. 95% will be perfect and 5% will be this side and that side, of errors or people who do not respond. Now coming to the benefits of clinical audit. Clinical audit is used as a method of measurement in all clinical areas. The scoring system is fairly simple. The results can be easily understood, and it assesses the work of all those involved in recording the care. Clinical audit is a useful tool as a part of quality assurance program in areas where accurate records are kept. Now, coming to the clinical audit report. Now, first of all, in the hospital, people find it difficult to choose a topic. Now, somebody will choose a topic because somebody else has done the same topic. They refer, in that hospital they have done that, or in that department. So I would also like to do this audit on this topic. Then understanding what is the area of concern. So as I had already said, you have to choose the area of concern which requires improvement and accordingly choose the topic. And once you all do audit, the report of the audit has to be properly summarized. So that also is an area of concern in many of the hospitals. People do not compile the report properly. Nursing department do a lot of audit. They have piles of audits and reports, but when it comes to compilation, they fail to compile it effectively. So kindly note the template for compiling a clinical audit report. It should have the project title. It should have the details of the project lead and other members of staff involved, the introduction or the background of why this topic was taken, why it was taken, what was the requirement or need, and was it really of concern, and whether a quality improvement in that area is required. Now you have to also write your aims, objectives, and standards. When you mention objectives, please use verbs such as improve, increase, to enhance, to ensure, to change. So you need to frame the objectives properly. As I had already mentioned, the methodology, including the data collection methodology, has to be mentioned clearly. If you are observing, using a questionnaire or a checklist, if you are interviewing, all these things have to be included in the methodology apart from your sampling. And then the findings or the results of the audit has to be documented. After which, the team has to sit together, analyze properly, propose various changes required or the action plans. So that has to be put in recommendations, and then you have to prepare an action plan. Now after which references and appendices, if any, has to be attached. So this is the template for a clinical audit report. So coming to action plan. Action plan is a major area of lacunae. Everybody does audit and finish after doing one audit. They do not re-audit, or they do not have a proper action plan with specified timelines. So as it is as important to have your aims and objectives and your findings, action plan is equally important, and everyone, the team members, have to pay attention to making an effective action plan. It should be owned and supported by all the stakeholders involved, and also supported by the management. Otherwise, the implementation of action for some of the problems may not be possible. The action plan has to be concise, simple, and it has to be precise so that everybody can understand. Action plan should be preferably in the format of SMART. It should be specific. There should be goal for your action plan. It should be specific. It should be measurable. It should be achievable. It should be relevant, and also it should be time bound. In the action plan, the responsible persons must be identified, and by when the action will be completed, it should be mentioned. So action plan should be having the action items, the responsible person who will be carrying out those actions, and by when those actions will be completed. And then this has to be revisited regularly and updated, whether how many points are closed, which are the pending items, why it is not closed, whether all are following timelines or not. This has to be revisited regularly and updated, and this should be widely communicated among the members of the department so that everybody can cooperate and contribute to the action plan. So this is a template of action plan. Coming to the barriers of clinical audit. Now all are busy with their work. Everybody have patients to take care, and now with the pandemic and other issues, nursing shortage, everybody feels normally lack of time. Oh, how to carry out an audit? We have no time. And then some will use checklist for audits as just tick list, which is strongly not allowed. If you have to do an audit, you need to properly do it, sincerely do it. Lack of time should not be excuse. Yesterday also we had a webinar on time management. If you plan and prioritize, definitely within the time limit of our work schedule, we can always contribute to the audit. So lack of time is one of the barrier which everybody normally complain. Lack of training in clinical audit. People do not know what clinical audit actually is, what is the difference between clinical audit and research, and various aspects of clinical audit, because of which they do not have the confidence to carry out the clinical audit. Lack of support from the management. At times when the staff are enthusiastic also, if the management is not supportive, then this is a barrier to clinical audit. Sometimes people may fear that clinical audit will be used negatively. If they are collecting data, maybe it can be used to victimize a staff or a group of people, so that fear may be there. And also the problem with the data, sometimes data can be biased if they are not doing a proper sampling. And the perception that clinical audit is dull and boring. And some feel that clinical audit doesn't make a difference. It's all, just documentation, collecting data. It doesn't make any difference. And the most important difficulty, which while interacting with others, what people have given me a feedback, is difficulty in identifying appropriate topic to the audit. To carry out a successful audit, good planning is very much required. So you need to plan, you need to identify areas of concern, areas requiring improvement, and whether it is a clinical audit topic. You have to make sure that it's a clinical audit topic and not a research topic, or not just for service evaluation. So a good planning is required for even forming a team. And then we have to do a pilot study if required. Sometimes if your hospital is big and you're covering all the inpatient areas, so the data will be so huge, it will take a longer time. So initially start small, just identify one area. If you're doing a study on fall prevention among elderly, take one ward and do a pilot study where elderly patients are admitted. And then based on that, then roll out the study to the entire IPD areas. As I earlier mentioned, the topic has to be clearly and concisely stated, which should be simple and easy for everyone to understand. It should be a measurable and achievable target. The team members have to be involved. Many a times in a hospital, clinical audit is done only by quality people. Quality department alone runs around, they just make some documents, they doctors, be it the nurses or the physiotherapist or the dietitian, who all are the members of the or the operation team member, all the members of the multidisciplinary team required to carry out the audit, all should be involved. Only if all are involved and all are made to understand, all are involved in the decision making, all are involved in the action plan, the clinical audit will be successful. It is a must to re-audit till you achieve the desired target. Your audits should be based on standard guidelines and criteria. I had already mentioned there are lots of international guidelines, especially NICE gives lot of guidelines on various topics. You all can go and Google search and find out. And for various guidelines, nationally the guidelines are not available that much, but international guidelines are available. So if you're doing an audit based on international guidelines, definitely you should be able to publish your audit report in national or international journals. Normally we keep doing lots of audits, we share the audit report with the management, with our department, and we finish there. We should, and the team leader or the HOD of the department should encourage the team members to publish the audit report, not only in journals, but also to apply for various quality awards. Lot of quality awards starting from Quality Council of India and various other organizations conduct various competitions. So you all should apply for that, and then the staff, when you get a reward, staff feel more enthusiastic to do more such audits. There are various examples of clinical audits. You can do for reduction of incidence in pressure ulcers, fall prevention among vulnerable patients, audit on medication errors, audit on implementation of early warning signs. So by implementing early warning signs, how did you reduce the number of code blues? You can do it. NHS has given beautiful, flow chart on early warning signs for adult, for pediatric, as well as for obstetric patients. Normally in the hospitals, you find for adult patient, but you don't find for pediatric and obstetrics. Please implement that and see the change. And how did you reduce the number of code blues? Audit on hospital acquired infection rates, audit on intravenous fluid therapy. NICE has given a beautiful pathway on intravenous fluid therapy. So whether your staff are following those guidelines, where you stand, what all changes are required, and how it can be improved, do a study on that. Audit on contamination of blood cultures. So many a times if the nurses are not handling properly while taking blood for culture, it gives a false report. So you can do audit on that. Audit on postnatal care, prevention of hypothermia among newborns. Numerous topics are there, but all these topics, if you're taking, you need to follow the cycle which I mentioned earlier. Exactly on that cycle, you need to put in, identify your topic, define your standards, aims and objectives, and you have to prepare, do a thorough analysis. Analysis is of utmost important. Analysis and action plan, these two are of utmost important while doing a clinical audit. So if you do this, these all can be done very nicely in all your nursing departments, and definitely that will help nurses improve their knowledge as well. And also wherever there is a lacunae, you all can take a lot of in-service education sessions as well. So to conclude, I must say that quality is not an act, it is an habit. So quality is all about changing the routine things which you are doing, which requires improvement. All improvements will require change, but all change will not result in improvement. So when you're doing an audit, if you're putting some changes in place, and when you're re-auditing, if you're seeing that there is no improvement seen, again you have to do an analysis and again propose a different action plan and do the change. So it's all about implementing those changes, accepting those changes, and sustaining those changes. As Aristotle has mentioned, sustenance, and it should, by sustaining those changes, it should become an habit. It should not be done just for the sake of audit or just for the sake of inspection, but for our own satisfaction and for our own improvement and for the improvement of our department. So with this, I'd like to conclude the session. And once again, I'd like to thank the organizers of CNRS for this opportunity, and thank you all the participants for your patient listening. Thank you so much.
Thank you, ma'am, for your word of wisdom. And madam has enlightened us with various different action plan for clinical audit, like SMART protocol. She has said, she has differentiated even about clinical audit and research. And at the end, she has said, as a tip, we can say, like, to carry out a successful clinical audit, we must have good planning. We should do a pilot study if required, and we should involve more team members. And ultimate, the most important thing is we have to share or publish your audit report. So she has quoted various examples and guidelines, and we are so happy to have Madam Bobby Ramesh. And thank you so much, ma'am, for reflected us with your word of influence. It will be a great pleasure for us to listen you again in our future events. So once again, thank you, ma'am. We are moving to our next session, second session, that's on evidence-based practice in nursing. Nursing research is important to generate evidence-based practices to provide high standard of nursing care service, which are cost-effective to the care providers as well as care receivers. Our next session is on those topics. To unfold the topic, we have a person with distinction who has taken her level of excellence many steps ahead. We deem it a privilege to introduce our next esteemed guest speaker, Ms. Deepa Chu, who has completed MPhil in nursing on CVT nursing, and currently she is the head of nursing service and principal of National Heart Institute, New Delhi. She has total 17 years of experience as various domains in clinical practice and administration. She is an NAPH assessor since 2017, and to her has done many research projects and published scientific papers in national and international journals, and she has been expert at various forums. Coupled with an impressive background and a passionate dedication towards nursing always inspires us. I am absolutely delighted to invite a charming personality from nursing profession, Ms. Deepa Chu. We welcome you, ma'am. You, ma'am. And please unmute.
Thank you, Chris. And thank you, the organizers, especially Madam Uma, through whom I got to know about CNRS, and delighted to have around 200 plus members who have spared in time on a weekend to join in. And amongst these members, I was going through when Madam Bobby was speaking, many eminent personalities are there. And the topic is such where I feel that there are many of them would towards the, this is my request, that towards the end of the session, few of these expert leaders and stalwarts who are sitting in the participant side should also be given encouragement to speak and let their views be pitched in, because I have tried to, whatever I have done, whatever I have practiced, and whatever I'm trying to practice it in the day-to-day activities of my hospital, be it this hospital as well as the previous one, I have tried to just put it that. My experiences I have tried to put in, but a little part of the theoretical background also, if someone amongst, there are so many teachers, amongst them doctorate people sitting in the participants, would love to join it, and it would be a better learning for me too, as well as from Bobby Madam's side also. I would share my slide, just a moment. Sorry. How do I do it? I'm not able to share it.
Yes,
Yeah.
yeah.
Yeah. So basically, what I would be telling in bits and parts, as well as try to incorporate few of the researches which we have done it in our place, as well as few which were done in the past and published in few of the journals. We have tried taking those in our clinical practice, and how this clinical practice have been really coming up good, and incorporating the evidence-based research which have been published, and we are doing it, those into our clinical practice. The basic parameters on those would be discussed. So basically, when we start with evidence-based practice or evidence-based nursing, it's basically the purpose behind it is that our patient, the rule of thumb, patient who is there, should be benefited, be it in the hospital, be it any procedure we are doing for the patient, the background through which we are doing these practices or inculcating these practices amongst our staff so that the patient is benefited. Third is in the community also. Community at par with from all perspective, from a newborn child to a geriatric patient. So basically our entire emphasis is to absorb that knowledge which is there and then give it to our utmost important, and because of whom we are there, is our patients. So the basic competencies which I've just tried to minimize it to the basic core which we require area would be into using the research. One is interpreting. Many a times we read a research, but we are unable to interpret it. And if we are interpreting it, how to use it? If I have a patient, how am I going to use this research into my practice? So my interpretation will be strong only if my subject of research is strong. I know the background of research very well. I'm thorough with it. So then only I'll be able to interpret it well. Second is I would be having experience or trial and error method, or I should be having the empowerment to utilize this research. And that can be only gained if we become the leader. Even a staff nurse can use it. I have seen few of the staff nurse, they do some simple kind of things, even for removing the air in the line. They are using it, but they don't know exactly that, yes, this is a thing which they can start collecting data. So basically, that is the competency which we need. Then evaluating practice. Once we have used this in our practice, was it useful, or are we just pressurizing our nurses to follow something because one of our MSc nursing student have done it, so let me just put it into implementation? No, that should not be there. And that's the right thing, what Madam Bobby said. Use your clinical intelligence and your experience and do an audit. So the best method is, if you use any practice, any clinical research which was done and putting it into practice, do an audit to find out whether it is useful or it is not useful. Your patient has been benefiting or not been benefiting. And then encourage your basic bedside nurse who is there, maybe a trainee, maybe staff nurse, nursing officer in charge, sister, whatever you want to call them as, encourage them to use that. And slowly, if not everything, they may not be with their methodology, not know how to do review of literature and everything, but data collection, why can't we use them? Why can't we train them for data collection? And it has been done. We have done a small project on IV therapy, and it came out wonderful because staff nurses who were there, they did the collection of data. So these are the basic competencies which a nurse would require when we want to use evidence-based nursing in our practice. Certain factors which are very important to remember before we go into the practices would be, first and foremost, all the researches which are done should be published. Till the time these researches are not being published, many a times what I see now, it's a race to publish for the student to get the degree or to get a job, for the faculty to get promotions or to get betterment in jobs. I would be sorry to put it very bluntly, but this is the fact, and let's accept the facts. Next is implementing the change. Whatever, say basic. I remember when I was a student, fundamental of nursing, we learn all that damp dusting here and there and everything. I don't know, I mean, perspectives have changed. Are we going to continue this, or we are going to change it? And if we are going to change it, what is the method by which we change it? Indian scenario, how are we going to change it? So implementation of your change should be very, very formal way. And skills in assessing and analyzing your research. Personally, I feel that whenever it is a hospital, there is no library for the nurses. There is only a medical library. And I'm sure all of you all will stand by this word. Very few, I am not saying all hospitals, but very, very few hospitals have a nursing library with good nursing journals in it. How many of us have it? And if we have it, consider yourself working in a very, very lucky, you are lucky enough to have it, and you are lucky enough to working in that type of place. So accessing these researches is very important. How are you going to access it if you do not have journals? Secondly, if you are not with associated with groups like CNRS or any other organization who are publishing and who are encouraging nursing research to be on a dialogue basis, then we'll not be able to. Yes, PubMed is there, but if you remember and if you have seen, you just get summary of the research. You do not get the entire research to know what was the discussion, how am I going to implement it, was there anything which is being projected by the researcher that this was the lacunae in it. So for the researchers, I can't be doing it through PubMed. So PubMed, yes, it is important. Google is our Swami, accept it, but when you get an abstract of a research, there is a proper methodology through which you write a chapter. If you access that, then only you will be able to analyze that research and you will be able to implement it in your clinical area. Otherwise, it's just halfway. It is just copy paste from here and there and try and do just because some other hospital is doing, some other college is doing, so let me also start doing it. So that would not be accepted at our levels, and being leaders in the fraternity, we should use our accessing skills, develop your own hospital's library, making sure that you may have medical journals, very appreciable, but you should fight for your nursing journals also. And believe me, you will get it. Few steps, this is just which you already probably would be knowing it, just briefing it. When you have already a research which is there and you want to use it in your clinical practice, one is the research utilization. How are you going to, you are going to use this research utilization. Then before you implement it, you would require a proper review of literature. These two steps usually go simultaneously. It's not that once you start utilizing and then you do the review of literature. Usually they are simultaneous, that you have read something and you have experienced in the clinical side some hitch and you want to do a particular research, or you have read about a research which is you're having good data on it and you want to implement it. So it's vice versa. Meta-analysis, it's a topic by itself. So I would just put it in a nutshell and say that it is that you are gathering the similar kind of research. Say IV therapy, you want to have a research which is there on IV therapy, some X topic. Now you will collect all the data from the Google search or maybe PubMeds. You may have some personalized in many of the colleges nowadays. You have soft copies of various journals, hard copies and all those things. You have got say 100 odd researches. Now the compilation of it gives you the N value, that is your sample size becomes bigger, your decision makings becomes bigger, your analysis becomes more strong, and your topic which you are reviewing becomes more robust, so that you can make good clinical decisions and utilize these in your implementation of a research. I will give you an example, few examples in between, so that it becomes easier. So just after this, I will give an example. So whatever slides we have done, it would give you a clear picture. What are we talking about? Some critical features which are required are you should have a problem-based approach. In evidence-based practice, you should have, like if a nurse or if in charge nurse or administrator is facing any difficulty, that problem can be searched through your review of literature, and then you can identify, okay, these are the researches done by our nurses in clinicals in Indian scenarios. We can implement this, we can definitely try putting it. So it should be problem-based. considering the practitioner's clinical experience. If I am in critical care area, I would like to do those, I would like to select those topics. I would not like to select topics. I would not like to select topics. Because mental health expert is there, would not like to select a topic on critical care or vice versa, you know. So it brings together the best available evidence and the current practices. You have evidence and you are putting it into your current practices. So it's bringing the gap which is there together. You are bridging these things. Then facilitating the application of research findings. Whether the research which was done has given you a particular finding, whether these findings are actually there or not, or it was fake, because majority of the data which is there is being seen that it's a lot of it is poached, a lot of it is just done and not authenticated. Many of it is being seen. So you have to have, first of all, good journals through which all these, you know, jisko hum bolenge chhatni ho jati hai. So use those kind of journals, use those kind of database which gives you authentic data, and then it facilitates you for your research implementation and your findings. Or are they not collaborating? It may happen that you get a different result completely. So that can also happen. I give you an example. This study which we did was on COPD patients, because what happens is if you see all COPD patients when they come to the hospitals, we have enough of patients in our hospital who come. The moment they come, their saturations, obviously they are diagnosed with obstructive disease, so they would have saturations which are down. But the moment any RMO or a nurse who is there in emergency or in ward also, when they see, okay, the saturation is dropping, the immediate action is oxygen laga do. So they take a oxygen cannula and immediately insert a oxygen cannula and start with oxygen. Less than 6, they would try, they are very tuned into it, that, okay, COPD patients, less than 6 liters. So the foremost thing would be that. But where is the nursing measure? Is oxygen therapy? Yes, oxygen therapy is a nursing measure, but it's not the requirement of the patient. If you go through the, then I do not want to divert my topic, because if you know the pathophysiology of COPD, it's not the oxygen which they require. So you are diverting into a different side. So what we did is we tried doing a lot of review of literature, and we found that there are certain positions. If you give these positions to the patient improves their capacity, and you know, your saturations and your PEFR, that is peak expiratory flow rate, which is there, it improves, respiratory rate improves, and the patient is at ease. We did this amongst our patients who were in ICU as well as in the ward, and definitely the purpose was that the patient should improve their PEFR and RR. For this, we had a basic tool which was done, was a biophysiological assessment sheet was made and a performer sheet. Particular minutes were counted. Okay, these many minutes the patient would be in this particular position. So what we found out is that we had these 5 positions, and we found out that if you make the patient stand, you get a very good PEFR, and either you make the patient upright, sitting, like how we all are sitting right now, right? Upright with back support. And there was one more without back support. So they too have a similar kind of, we got results of it. But if you make the patient semi-Fowler's or supine, the PEFR drops down. So whenever a patient comes with COPD, the standing orders for the nurses is do not put immediately. Yes, if an emergency patient comes with an exacerbation, obviously you are supposed to do something, or maybe a patient may require a BiPAP also. But say a patient is admitted or stabilized, but patient is not able to breathe properly, or you are feeling the saturation is going down or anything, just make the patient stand if the patient can. If not, give an upright position, and there have been improvement which have been seen. So these have to be very, very competent in ECG analysis. I would not say analysis, I would say interpretation of ECG, especially in case of acute MI, because we can't waste time. Maybe the doctor is busy. The moment the patient comes in the ER, the patient is rushed to the ICU, and the ECG has to be read. The nurse who is taking out the ECG should be so quick that she should know that this patient is of MI, because if we have acute MI case, we just have 60 minutes in our hand, whether it is a primary PTCA to be done or any other procedure to be done. We just have very less time. 1 hour is told by American Heart Association. Nowadays, hospitals are looking forward for less than 1. So our targets would be definitely half of it, and maybe too tight to achieve it, but yes, we try to achieve. We try to put this patient on thrombolysis therapy or on a primary PTCA, because our nurses were able to interpret. Now this study, which there were too much of attrition during that time amongst our nurses, and there were a lot of nurses in the critical care area also who were quite new. So we tried doing this. We tried formulating assisted self-directed learning, wherein ECG interpretation was given more importance, though a brief knowledge about ECG was done, but interpretation was our main aim. Now, with this, we had just a very small questionnaire, just hardly 7 questions, I guess, yeah, 7 questions, and a workbook. That workbook had all acute MI ECG strips, wherein the nurses were trained, okay, to find out if there is acute MI, different areas of the heart, anterior, posterior, and lateral, and this and that, and all. That is again a different wide area. So all those things were taught to them. It was a self-learning module kind of a thing which was made, and along with that, a workbook for them to practice. And behind the workbook itself, there was a test which was being given to them. And once we started doing this, we saw that the nurses were they became very competent, and now it has become a part of our in-service module as well as induction module. The moment any staff joins in, at least for a MI, because that's our prime area. National Heart Institute, the name itself says that's our prime area. So this came out to be wonderful, and we have included this into our induction schedules as well as our CMEs, and it has worked wonders. Till date, we are using it, and we are very happy with that. And everyone knows. Now, if any nurse has made any mistake, even the doctors know about it. They say, "Oh, workbook lekar aao." So, our critical care doctors also are knowing about it. They have also kept these books with them, these small handbooks, so that it is easier for them whenever they are free. They also, rather than chit-chatting, just have a discussion. So this was, what we found in the pre-test and post-test, and we are using these. Okay. Just a brief about the process of evidence-based nursing. One is you have to identify. I am sure the entire the participants who are sitting knows about it, so I'll just go in a very, very quick session into it. Identify your topic, conduct a review, evaluate the current practices and the gaps where you have, develop the protocol or a practice or a policy, whatever you want to call it as, you can do that. Disseminate the information. Now, many a times, many organizations have personally gone, beautiful policies, beautiful protocols, wonderful is not the name to be given. You will get an awe to see these policies. But when it goes to the staff nurse, you ask them, they are unaware about it, because it was made at a leadership level and it was not percolated down. So disseminating it to your people, disseminating it to every nursing staff who is there at the bedside, who is going to actually implement this, is very, very important. And to evaluate whether they have got exactly what you are trying to tell them, or is it a different, the tangent cause gone different, and you may go into a primary research. Again, I get to a small study which was done. This was definitely not done by me, by a very eminent personality. I was a part of it, so I know it. wonderfully done. It was to find out the effect of planned audit on compliance of nurses' performance to audit criteria on hemodynamic monitoring. So audit criteria was made. So a nursing audit was done, and this was put into a research based, like what Body Madam told. You can use your audit into a research. You can convert this in, if your data is larger, you know that you have a methodology to it. You can convert that and put it into a research, and then definitely you can publish it also. So here it was only an audit tool which was used to measure the compliance of the nurses and what was the effect of it post. So this was what you see, that you know how effective. And it was not only, I have taken only one parameter of the hemodynamic monitoring, because if I have to take all parameters, then there will be a lot of them, and we'll be discussing on only one topic. These are just briefs. I'm trying to tell you that these are certain things which we can utilize it in our practice. It's not that it cannot be, because there was one person in the participant who said that these many researches are being done. Are we going to utilize this in the clinical practice? The answer is yes. Yes, we are going to, and we are. But if we are only doing amongst nurses and asking their knowledge, sorry, then being a leader of a hospital, I would not like to irritate my nurses so much that I'm just going on asking them questions and they go on giving me answers. So knowledge, attitude, and this and that, I don't know. I would not prefer doing that. But well, if it's a good one and need-based one, yes, we may. One study, this is yet not published. We are still, trying to prepare its summary and everything, the last part of it remaining, but basic part of it is over. So I would like to, portray this study of ours. Wonderful study, and believe me, this has done wonders to our patients. There are few studies which we have implemented. This has wonderful effect and wonders to our patients. We have used ice packs, and just before 15 to 20 minutes before removing any invasive line. So the 5 lines, if you see in the purpose, the 5 lines which we have in our post-operative patients, because this study was done amongst our post-operative cardiac patients. So chest tube, arterial line, central line, and pacing wire. Majority of our patients are having these 4 lines. So that's why we selected this. Now, when we remove this, for the chest tube and all, you would see how we would put the ice pack directly. We can't do it. So you know what we did? We used the ice pack, the ice gel packs which are available for breast engorgement. It's a semicircular kind of ice pack gel form. It is available in the market. We bought that and we started putting it 15 to 20 minutes before removal of the chest tube. Usually this is done early in the morning. So whoever did it came early in the morning, started doing all these. So one by one, when we started doing it, we got wonderful result. I'm just telling you about the chest tube removal. You see how efficiently it was. I mean, how beautifully you see the significance is there, and our patients have been really very useful. And we have not been using analgesics for these patients. Our doctors have stopped prescribing analgesics from the time we have started doing this, and we are continuing it. Now, it's not that evidence-based practice. Chris, do I have time? Can I just take 5 more minutes? Chris, can I take 5 minutes more?
Yes, ma'am.
Yes. So, because I think I'm running short of time. So if not, then I would skip and I can share my slides. So there is nothing without a problem. There would be problem coming, but wherever there is a problem, there is a solution also. So time is the utmost problem. The same was being emphasized by Bobby Madam also, but there is a solution. One is, if you require your practices to be on grounds being functional, then you have to look at your cost benefit, work up all these things. These are all in the planning phase. So plan it very well. Small achievable goals should be made, and see that everything is in line. So you see whether whatever practice you are planning to put it in your nursing practices, it should be screened well. Resource requirements, for that, the first and foremost would be empower your own clients, empower your own patients to ask for what you require. Say, for example, this, this ice pack which was there. We found that patients used to ask us, his sister, because there was one patient who was having some other line also. Few of the patients have additional lines also. They would ask, his sister, is line pe ice pack nahi lagayenge? So, make your patients your advocate. Ask, tell them to advocate for it. Then it becomes a policy itself, and management or any hospital would not deny to it. Then your access to knowledge, access knowledge of individual people who are going to perform it. Have you given them enough knowledge? So assess their knowledge and give them, share with them resources through which they can, widen their knowledge also. Distance, if there is a problem with the distance, to implement this is the best time to learn. Pandemic has taught us how with distance we can work together. Like, we are sitting, we are having a webinar. One is sitting in Chennai, another one is in Hyderabad, another is in Pune, and so this is the best time to learn. So use of your electronic media, your networking sites and everything, and your leadership quality works a lot. Lack of confidence can be overcome through training and making small achievable goals. Don't ask your nurses that you have to pluck 40 stars today. No, it can't be done. You have to first tell them to reach the sky first. Right? Then only they can pluck stars. Then demonstration of projects. If someone has done it, project it. Motivation in short form. Lack of information from nursing success. Mainly it happens that we are not motivated. We are not getting that kick to do it. Adrenaline rush is not there. So by that, if you want to have that, put more and more research and publish it. Increase your access through various, we have a beautiful talk show also, which Uma Madam has started. Madam Rupa is there. Wonderful. That is what is lack of information which is there. It narrows down. We are then open. We are able to talk with each other, and we can articulate our practices, what we are doing. Few barriers. This is again, these are all available for you all. Just to brief it, accessibility of research findings. We have spoken enough about it, and anticipating outcome of the research. See, if you are already anticipating, okay, in a research study, this was the outcome, so I would also get that. So that's a barrier to your practice. No, it may not happen. Say if I'm telling that use ice pack for removal of your invasive lines, it works wonder. Probably it works wonder for us and we have found out to be effective. Maybe in your patients it may not work. Or maybe your patients feel that it is too cold for them to take it. So don't go with that preconceived ideas of it, then it becomes a barrier. Then organizational support to be using researches. That I feel no organization would support you until and unless you put it forward and put it that it is be beneficial to your patient and is economical also. Support from us to use research. To use it, everyone follows it. Believe me, it happens. You, a small group, or who would percolate it down and they themselves are using it, it happens. I have done it, so I would tell it with confidence that it happens. Essential qualities, all of you all know it, just to brief it: critical thinking, culturally competent, knowledgeable coordinator of healthcare. So all of you know about it, just to brief, just to brush your memories. It is. There was a study which is done on, I tried to take that entire studies gist of it to my PPT. This was like sources of practice. From where am I getting this knowledge that I use in my practice? From where am I going to get this? One is from each client as an individual. Every patient of mine teaches me. That is the rule of thumb. Again, remember it. That's the rule of thumb. Every patient teaches you something. Every patient asks you something. So those questions which are there should go as a question mark for your evidence-based practice. Intuitions, personal experiences, and you have the mean values over there to see it. The nursing schools or colleges, fellow practitioners, we are working with each other. Maybe it happened, Bobby Madam tells me something, Rupa Madam tells. COVID, from a simple steam inhalation to remdesivir, everything is available, right? So you can use these therapies. Professional journals, you get to know your information. Textbooks, what has worked for me for years. Many of the senior nurses you talk to, I've been doing this and it has worked wonders. I give you one small example. I'm really running short of time, but I need to tell this. Something which really has worked with me is, if any patient, in spite of, because there are lots of causes for bed sore. Let's not say that if a bed sore is there, the nursing care is bad. It can be bad for a normal patient, but if a patient is a renal failure patient or many other criteria, then the patient may develop bed sore. Say if the patient has developed bed sore, what I have done it, that's why I'm trying to tell you. I started using, I saw this using in my student time, burns used to round kind of thing, mesh work, which is for, we use it for the burns patient. So I started using this for our patients who are having bed sore, and do not the patients any cloth touch that bed sore, and keep it open, and over it put a bed sheet. And it has worked wonders. Only oxygen therapy and normal air has worked wonders for these patients. And so, though I want someone to do a research on it, and I've been thinking of doing it, it has not been materialized. You know, so this is what I have done for years, and I have got it practiced. Every patient who is getting into grade 3 bed sore, or at times we get patients of grade 3 bed sore, those patients, we use this therapy. We put this cradle, burns cradle, and let the patient have training and conferences. Like, you know, when we chat like this, we get to know many things, and we need to improve our practices through this. Many policies, procedures, like Madam was telling about, nice guidelines. It has wonderful practices, and we can definitely do a lot of as well as implement. The internet is loaded. Sony is there to give us a lot of data on it. Now, sources of information, I think I should skip this. It is similar. Just a small study, which was my master's topic, was on effect of foot massage, which most of it was on reflexology. I'll not go in the depth of it. All the physiological parameters were assessed, but a part of the physiological parameters, the patient got beautiful sleep. They were like, oh, we get an awe when you do this, and we get good sleep that day when you do this. So, you know, a part of this, I also got good results on sleep. Another one beautiful study, which we are using it for our patients in dialysis. I think this is my last, so I'll stop it. I know you're ringing the bell. Okay, this is done for you. Huh? So this was effectiveness of nursing measures. We used 3 measures, that is intradialectic leg stretching exercise, warm moist heat, and ginger powder on muscle cramps for patient undergoing hemodialysis. Because we have seen this staff of mine who is working in hemodialysis always complains of patients having a lot of cramps. There are a lot of reasons. You all can read about it. And majority of the patient, I would say more than 90% of the patients, they get cramps. So we did this study, and warm moist heat came out to be having wonderful effects. Intradialectic exercises, it requires a lot of compliance from the patient also. So many of the patients do it, but when you tell them, okay, you are at the next bed, you do the exercises, they may just, you know, stop doing it, or they feel lethargic to do it. So the best we got is warm moist heat. Intradialectic exercises before the dialysis, when we did it, also was very effective. And something which was very unknown was ginger powder. Ginger powder also worked, but, you know, more than muscle cramp, if we had put this in the discussion point of view, that ginger powder worked wonders for constipation. Patients came out asking for this nurse, sister, wo powder de dijiye, hamara constipation dur ho gaya. So this was like, wow, this is something which is not written in. We tried finding out in the review, a lot of journals we have seen, but we did not get any data on it. But this is for someone to do it. But these work wonders, and every patient now asks for. Even if the nurse forgets over there to give warm, moist heat, we have now made these towels like a roll, which can just be put in hot water and put on the legging, like a legging to our patients. वो डाल दो 15 minute के लिए, just छोड़ दो patient, right? So patient have very less cramps and medications have gone down. The doctor who is there has laurels, and he has presented this in one of the medical seminars also. And he came and congratulated us, saying that it was really appreciated in their side also. And very simple clinical performance. There were very less number of puncture site complications, and the lower extremity flows are wonderful. We practice it for every patient. You see the results over here has come out wonderful, and we do it for all our patients. So this is, I think, from my side. Chris, I'm so sorry I have taken additional time from you, which I shouldn't have. And I would love if participants would add and pitch in something, so that we get motivation to practice more and more. Good work which you all have done. Ma'am.
I saw a lot of questions from the audience. So first, let us, as we are running short already to 5:25. So if the moderator could share the questions with us, so that we can answer those questions.
And before that, excuse me, before that, we have Madam Uma Hanja. She would like to speak.
Sure. Thank
you. Thank you, Madam Tibachuk. You have really expressed a lot of things, and because of time constraint, we couldn't hear you. But we are sure that our participants are really mesmerized with your it was really wonderful. You have quoted with various examples. That is really needed in now these days, because people don't read, people don't. As you said, publishing in nursing journals, we must more focus on that. And you are a really visionary leader, which I must say. And we are so happy to have you, Ma'am Dibacho. Unique blend of charisma, vision, and character traits to attract other people is just enough to achieve heights in any field. Let me take this opportunity to invite inspirational, legendary Indian nurse leader, Madam Mrs. Uma Hanja, a visionary leader with a talent of clear focus on this goal. She is our driving force, and personally I can say she is another inspiration of me too. And I should say, she does not believe in being static at this age. She believes in seeing what is lacking and keep moving as per need of the time. And presently, she is our advisor. So may I welcome Madam Mrs. Uma Handa to share her experience in ways related to evidence-based practice she has done in her time. Madam Uma.
First of all, and given, it's not only the talks, but they're very, very practical suggestions, which will definitely help us to improve the standards of our nursing practices if we follow them. And I was really impressed by Deepa's that they're doing the small, trials. I would say about the trials, that trying to change the practices for betterment of the patients, and seeing that they're helping, and then trying and implementing them. That is what is required. But there, I would say that it will be nice that if they can, have more, like the correction is that I'm not just, for the nurses talk is not started by me. It is by Rupa Rawat. So the way Rupa has started the nurses talk in such spread what are the good practices you're implementing in the area will be wonderful. Now, I will just take about 15 minutes to tell you my studies, which were research-based. At that time, research amongst the nurses was not very common. Either it was done by the BSc or MSc nurses, or introduction of research methodology at the BSc level was done. Well, I did my study way back in 1977 to 79, while I was doing my master's. And I was, to select my problem, what research to find the solution to a problem. And so I was looking for the problem, and I was watching that my classmates, they were going to the libraries to read the other research studies which are done by the students or other researchers to find the problem. But I had decided that I am going to find the problem from the clinical area. So I was doing my master's in OBGY. So one day I was in the antenatal clinic and I saw a mother coming into the antenatal clinic, and she had a toddler in her lap, and her one breast was completely gone, and the other she was feeding her toddler with a dirty milk in the me. She was feeding she was feeding the baby, dirty in a dirty medicine bottle, diluted milk and dirty nipple. So I asked her what happened. She said my first delivery was also here, and the breast was abscess was formed, so it was incised, and after that this breast has become completely out of function. So that is the thing. So immediately it struck to me that I have to do something about that. So I picked up the problem. I am just cutting short so that because the time is not there. So I selected my title of my problem was the primipara, because multipara would know how to do it, but primipara would not. Primipara, antenatal preparation of the primipara to prevent the breastfeeding problems during the postnatal period. So my study was later on, when I finished my MSc, I got gold medal because of that. And with the result that this study was presented in various forums, and even my Foxy's president, he asked me for a copy of it. It was accepted by the Ministry of Health and Welfare, because I was working with UNICEF, and at that time, after that I saw that with modification of some practices, since then the mother started getting all the 6 months leave for feeding the breastfeeding. So this was the outcome that I wanted, that whatever I do, the outcome of it must be implemented for the betterment of the society, nursing, patients, so that the improved practices are are taken care of. Now, with the result that because of that, I got actually my posting in UNICEF for 4 years. I worked for UNICEF, and my second thing was this was the research study was that was on my own, and I didn't take any funding from anywhere, and nothing, no help at all, except the hospital where I was supervising the students. What I observed, I was posted in a maternity home to start with, and at that time, that was my first experience. That in the labor room, I saw that the midwives are cutting the cord of the baby as soon as the baby is born, and putting the baby to bath immediately, and that too in the wash basin under the tap. Baby would catch hypothermia, and then they would wrap the baby and put in the crib. Now baby would catch the hypothermia, and then they'll be hue and cry, and call the doctor, try to resuscitate the baby. Some baby did get resuscitated, but most of them did not, trying to send them to the tertiary care level, but on the way the baby passed away. And you know how much was the neonatal mortality rate was so high at that time. So I was very, very, upset about it. And I said, how can it be possible? And how can we let our babies go away like this? So I went, I was in Wadia Maternity Hospital. I went to the dean and I told her that I want to do this study. And she said, okay, make the proposal. I made the proposal at their go ahead, 200 samples purposely, because I thought that if I can do it, I will be able to see that this study is published and it is followed by others also. Now what I did was, I took my studies, title of my study was, mind you, 3 years, 0 to 3 years, and its relationship with hospital practices. So that I selected 200 newborns, and it was an experimental study. Now the 5 practices, the hospital gave me a lot of cooperation, and I was able to go ahead with this study. The 5 practices, you can imagine what I changed. All I did was, I said, there'll be, as soon as the baby's head is seen on the vulva, immediately the fan and the AC should be switched off, which is kept on for the convenience of the nurses and the doctors. Secondly, there should be no cross ventilation, though all windows and doors should be closed. Third, that baby should not be delivered in the pool of liquor amni and blood. And as soon as the baby is born, with a dry towel, wipe the baby, put the baby on the mother's chest, mother's breast, without cutting the cord, and let the baby and mother skin to skin warmth go to the baby, and also he's motivated, I mean, stimulated for breast, for sucking the breast also. After some time, cut the cord, tie the cord, and again clean the baby in a absolutely dry towel and wrap the baby in a dry sheet and put the baby next to the mother as long as possible. Now, these no bath for the next 8 to 12 hours. At that time, say 8 to 12 hours. Now, the modification is that it is for so many days, no bath is given. Now, maybe every 1 hour, the temperature should be taken to see that the baby's temperature is regulated or not. Is it normal or not? And baby should not be transferred, baby and mother should not be transferred to the postnatal ward unless both are comfortable and all the vitals of the baby and the mother are normal. Now, this was and the study did a statistical analysis, and it really had a very, very good result. And I showed it to the various doctors, and they were really very much impressed. In the meanwhile, I was transferred from Bombay to Delhi, and I wanted to, see that this recommendations of mine should be implemented. But unfortunately, the hospital where I started working after coming to Delhi, their pediatricians were not in favor of it. They did not like that a nurse has done a study like that. And they said, no, it's just nothing. It's nothing at all. We don't think that this need to be implemented or taken into seriously. So it happened that there was a big international conference in the same hospital. I don't want to name the hospital, but there was international press. All right, if you want to know, it was AIMS, All India Institute of Medical Sciences. A big international conference was going on, and I took my study to a doctor, Dr. Raju, who had come from, who's Indian origin, but who had come from abroad. And I showed him, I said, Dr. Raju, please, can you see this study? When he read it, he said, my God, for a tropical country like India, you've done wonders. And he took it back again to the head of the pediatric department, but they again said, no, nothing at all. And Dr. Raju, advised me that there is International Pediatric Association's conference is going to be held in Bombay also. And since you know the head of it, Dr. Ajit Mehta, who was the president at that time, you know him very well. He knows about your study. Why don't you contact him and you go and present the study in the Pediatric Association of India? I went all the way from Delhi to present my study at that time to Bombay. And, the outcome of it was that it was so much appreciated by the pediatricians that they immediately, Dr. Sundri Rao, I remember, she was from Hyderabad, immediately she sent my 5 recommendations which I had given to all the hospitals and the maternity homes for implementation. Now, these were the research-based studies, and just a small project like Deepa has explained, you know, I was posted at the Open University Sri Lanka, and we had to get some for distance education, basic BSc program. And, you know, we had to get some small projects done by those students. Now, all the students were, the students were divided into different batches. And my batch, when they came to me for the, asking me that how they should select a topic and all that, I said, you try and see how you can do it. They went to the library, came back, we can do on diabetes, we can do on anemia, we can do on this. I said, nothing doing, you will select a problem from the clinical area. All the other batches had selected their problem and their project problem, but my batch was feeling very disappointed. Sorry. So I told them, I said, where are you working? They said, we are working in the psychiatry ward. So I said, go and be there on night and morning duty in the psychiatry ward for some time and see if you find something which is not correct. Like Deepa's exactly the small study which, you know, immediately can be done and find the good results out of it and implement it. So they went and they divided themselves in the different units and they said, let's see. Then they came back running to me in the next 2 days. And they said, yes, madam, we have found the problem. Okay, tell me what is the problem. They said that what happens during the evening time when the lights are put off, I mean, not all lights, very few lights are on, and the staff is also very few. Most of the staff go off. There are only 1 or 2 people who are there. The patients, psychiatric patients, you know, they just, crouch in a corner of the bed and then they pet the pet because they don't want to go to the bathroom. So I said, okay, that's a very good problem. Come on now, you find out what will you do. I put it on them only. I didn't advise them that what they should. They let them find out what they can do to improve the services in that particular area. So they came back after 4 days and they had divided again themselves into different cabins and for different time of duties and saw the difference. And this madam, what we did, we found that because they are so frightened, so scared to get up, and they don't want to ask anyone because the nurses will not listen to them and shut them up. And so that is why, but we decided that we will do the study on this, see how we can help them. And I said, okay, that's very good. After a few days, they came back and they said, what we've done is, I said, what did you do? Put everything on them. So what we did was that we just, saw that there are proper lights from the bed to the toilet where the patient has to be taken, and there are enough staff on duty so that they can be assisted to go to the work. And that was it. And they got the now I'm that these studies, and it's the founder society. I'm proud to say about that. And that was the first society which was founded in India for nursing research by the nurses. And now it is 40 years old and there are more than 4,000 plus members. Now these things, I mean, I was so happy to hear from Deepa that, these practices, you feel that there is something which can be improved. And if you do it in your own clinical area and you keep on making more and more improvement and see for the benefit of the patients as well as for the satisfaction of the nurses, how much satisfaction does it give? So these 3 studies, I mean, research is my passion, and that is why Nursing Research Society of India and now the Clinical Nursing Research Society, I was very happy. And this, and of course, I was pushed. I'm 85 years old now. I thought that it is time that I retire completely, but then it is nice of Ms. Dr. Suresh Khanna, who really literally pushed me into it and asked me to take the responsibility of starting another society which can, be beneficial for the nurses and the young nurses, younger generation to come up, as well as for the patients, improving the standards of nursing care. Now, a little word about Bobby's, auditing. Again, a very, I always like to do small little things so that I know that there is something more which can be afterwards, finding less and then increasing. 5 minutes, I'll just take. We were having, just take 5 minutes more. We were having, I was working in another hospital in Delhi, and that is in 2000, it is in 2009, not very long back. Sitaram Bhartiya Hospital. We were having a camp for the antenatal mothers. And I was doing, actually my job was in-service education of the nurses. And when I was sitting in the antenatal clinic because I have my OBGYN, and I was getting very bored because hardly any patients were coming to me. So I thought that I must do something. I never liked the documentation of the hospital by the nurses, by the paramedicals, and by the doctors. I was not satisfied at all the way it was being done. So the hospital had already applied for the NHAB's inspection. I didn't know about it, but anyway, then I asked her. She was my director at Teams also. She knew me very well. And I asked her, I said, can you give me the permission to take 25 files from each department from the, where the documents are kept from that store, if you can ask them. She said, what will you do? I said, I don't like the documentation, the way it is being done. I want to find out that how we can improve on it. Four now I didn't go to radiology, pediatric, and the OPDs. Now what I have seen in the document that would come find that the doctor comes, the consultant comes with the senior doctor comes with the junior doctors for the round, and he will just speak and say, okay, he'll prescribe the medicine, is this, how is the patient, stay there only for 10-15 minutes, and then just prescribe the drugs and go away, and not even sign the document. Now the junior doctor will sign and write it down, and he will sign, the junior doctor. Secondly, in the same case sheet, at the bottom, there was nurses' records used to be mostly handed over and taken over, handed over and taken over. For vital signs in the report also, vital signs in the temperature chart also, vital signs in other documents also. So I said, what is happening? Now, I saw that nurses were, their notes very, I'm from, I know them from, just also writing underneath exercise advice, that's all. This will come advice. So I took it on that. I said, telling me, when you say that senior doctor prescribes the medicine, doctor signing it. First of all, that change should be made at that. Secondly, they will come and they will write down, give exercises. What exercise to be given to the patient? When this is given, nobody knows whether what type of exercise is given to that particular patient, whether the patient really required or whether the patient did the exercise. Patient has done the exercises. That's all. Nothing. No problem. Nutrition is soft diet advised, and or sometimes if there is any change, a patient can take full diet. Nothing at all soft diet, semi-solid diet, or what type of diet exactly, what do you think that the patient should have? Now I went and gave my report to cut short, you know. I went and gave my report after about a month to the director. And director was really, really so amazed. She said, "What is this? I mean, if I never knew that this is what is happening in the hospital." She asked me that, "Tell me, let me know what thing you think are." And I went to each and every department and sat with them and discussed with them that how these records should be maintained. And ultimately, the director changed the whole system, and overnight, all the documentation was changed as I had advised. So this was, I think, was a very great satisfaction to me that I was able to do it. Thank you very much for patient listening. But I think that at that time when people, I mean, not much care was given, attention was given to these things. That was the time when I thought that there is something is needed. And because of that, I've earned a lot of respect and name in my profession, and research is my passion, and I still continue to be always. And I think the next birth also I will be a nurse and a passion for nursing research. Thank you so much.
Thank you so much, ma'am. We salute you for your wonderful experience, and it was really this was a good experience for everyone. And I can see in the chat box how people were inspired with your examples. And we are so happy to have. We are running short of time actually. I would like to, before moving to question and answer session, I'd like to announce that the participants who are attended the webinar, please the form which is being attached here, so you can get your certificate within a week. So moving to our question answer session, may I start, ma'am? Bobby, ma'am.
Chris, I have seen 4 or 5 questions together, which was of my topic. So I think I'll answer it all together. Okay. Can I?
Yes, please. Yes.
So somebody had asked about whether clinical audit requires ethics committee approval, and ethics committee approval is not required for a clinical audit because it is not a research. Because when you're choosing a topic itself, you need to ask these questions whether it is for the purpose of improvement of current care, and whether the project involves measuring involves measuring the current practice against the specific standards, and whether it involves any experiment on the patient. So for the first 2 questions, that is, purpose has to be for improving care, and it should be for measuring against specific standards. However, it should not be for doing anything on the patient. So then in that case, it is a research which requires approval from the ethical committee. And for publishing in the journals also, clinical audit normally doesn't require any ethical approval. However, sometimes some journal committee members may feel that there is some ethical concern. If in that case, most of the hospitals are having ethics committee. If you feel that there is a concern, you can always take the approval. But routinely for a clinical audit publishing, ethics committee approval is not required as per protocol. Now coming to standards and benchmarks. Let me tell you, benchmarks are given by various organizations, nationally and internationally. For us, mainly it is international, because nationally so many data are not available to refer to. International benchmarks are there. For example, if you have to see, WHO has given a surgical safety checklist, so now all the hospitals follow that, all have to follow that. 100% surgical safety checklist has to be followed and documented for any surgery. So your criteria or the standard, you have to write like that, that for 100% of the patients coming to your hospital for surgery, the surgical safety checklist has to be completed. It has to be adhered to. And if you ask the CDCs for infection control practices, CDC guidelines we need to refer to. National Healthcare Safety Network gives different benchmarks for VAP, bloodstream infection, UTI, and SSI. Please go through National Healthcare Safety Network for infection control related benchmarks. CDC for various guidelines, WHO also for various infection control guidelines and the latest practices. So and also NICE has given guidelines for over NICE was earlier called as National Institute of Clinical Excellence. Now it is called as National Institute of Health and Care Excellence. It has published over 1,000 guidelines. So if you go through those guidelines, you can always set a criteria. Somebody had asked a question on how to set a criteria. For example, Deepa was telling about a COPD patient. So NICE has given protocol for managing COPD patients. As per the protocol, a COPD patient with acute exacerbation coming to the emergency should be assessed for saturation by the nurse within 5 minutes. So whether the nurses are assessing these patients for oxygen saturation within 5 minutes. You can always do audit on that. Your complaints you can target at 100% or 90%, whatever. But for some topics, it has to be adhered to 100%. For some, you can always set a realistic target of 90% or 95%. Similarly, for audit on infusion therapy, a NICE guidelines say that for any patient on IV fluids, there has to be a fluid management plan for 24 hours, in which all the fluids and electrolytes required for 24 hours should be documented, and it has to be reviewed by the physician on a daily basis. And also the nurses who are administering the documentation of rate of the fluid, which normally many of our nurses forget. When they write start time, stop time, they write, but the rate of fluid they do not write. When we go for audit, we check all this. So whether your nurses are documenting, if you expect 100% of the nurses to document, so if you're auditing the fluid and electrolyte therapy, whether there is a fluid management plan written for the patient, whether the nurses are documenting the rate of this thing. 100% of the nurses, patient case sheet contain this documentation. You can always audit on this. So that is how the criteria has to be set. For pressure ulcer, please see to the guidelines of National Pressure Ulcer Advisory Panel and European Pressure Ulcer Advisory Panel. So one of the protocol they mentioned there, any patient with a pressure ulcer should have a nutritional screening and a nutritional management being done for that patient. So whether for all the patients, especially we see that these pressure ulcers are being developed in the ICU, whether for these patients proper nutritional screening and nutritional assessment is being carried out, and accordingly the management is done, whether the albumin levels are controlled, and because people with low albumin get this pressure ulcers also. So please look into that. Similarly, many a times for surgical safety infection, when the root cause analysis is done, they say that the quality nurse or infection control nurse comes out with finding that patient was diabetic, so the patient had SSI. So that is no excuse. So glycemic control for post-operative patients and its correlation with SSI guidelines you will get from NICE guidelines. So many of it has got guidelines. Based on the guidelines, you can set the criteria. From that protocol, you can take the criteria and you have to follow that, whether you are following that or not, whether they are following that standards or not. Benchmarks, for few international benchmarks are available. Group hospitals, they, internally among all the hospitals, they calculate the mean or the average, and they, develop a target or a benchmark. Similarly, the hospitals who do not have to start with, at least internally based on last 1 year's data, they can develop a target or a benchmark. But for infection control, you have benchmarks available which needs to be followed. For medication error, ISMP, Institute of Safe Medication Practices, gives a benchmark of 2 per 100 discharges is acceptable. So you can set a target accordingly also. And also the one more thing I wanted to say is that somebody had asked about the quality improvement tools, what has to be used. There are 7 quality improvement tools: Pareto diagram, your fishbone analysis, 5 whys. So please Google search quality tools, whichever are appropriate to your the analysis. Please don't put a fishbone analysis for all the analysis. Many times people just make a fishbone analysis, whether it is appropriate or not. Where appropriate, use whichever is appropriate to that, whether it is a FMEA required, whether it is a 5 whys required, whether it is a fishbone analysis please do use appropriate quality management tools for analysis. Also, for any quality improvement projects, you have to follow a PDCA: plan, do, check and act. Plan, do, check and act. Once you check and act, and after acting again, you evaluate. If it is not the results are not effective, again check it, again you plan, the cycle follows. So these are various quality improvement tools which you have to use appropriately for your quality improvement projects. In our hospitals too, we have done audits on fall prevention among the elderly vulnerable patients, wherein there I remember somebody had asked a question on who are the members who have to be involved in the team for doing a clinical audit. As I mentioned already, clinical audit cannot be done by one department alone. It has to be a multidisciplinary team. That is a prerequisite for doing a clinical audit. If you are doing on a fall prevention, you can involve a nurse, you can involve the doctors, because doctors are the ones prescribing medicines, and some of the medicines are sedatives in nature, and the patient may feel drowsy and may have a fall also. So doctors have to be involved. Operations member from operations team can be involved, because sometimes in the bed the side rails have so much of gap and the patient slip through the side rails and have a fall. So those rectification of side rails have to be done by the operations team. So they have to be involved. So depending upon the topic you are taking, for prevention of pressure ulcers, dietitians have to be involved. Physiotherapists can be involved. So depending upon the topic taken, please involve a team which is multidisciplinary, and you have to have this checklist of why it was done, why this audit was done, how this audit was done, what were the findings, and what next. So these are the 4 questions you have to ask at the end of the audit. So these are the various questions asked by various participants. I think I've answered all the questions collectively. You need to Google search. NICE itself gives a lot of guidelines. So you take the guideline or the pathway, take one simple guideline or a pathway, implement in your hospital, see where you stand, what all are the steps you are not following, and what is the target you want to achieve. You can set a target accordingly and aim towards achieving the same. Thank you so much.
Thank you, ma'am. That was really wonderful. You answered all the questions which were asked with our participants. One question to Madam Deepa. Ashokan has asked, what is the difference between meta-analysis and meta-synthesis? Madam Deepa is there? Yeah, please unmute.
Yeah, you're able to. The organizer had muted me. That's why I was not able. Okay. So if you can repeat me the question.
What is the difference between meta-analysis and meta-synthesis?
Yeah, that someone asked me, but really I also need to work on it, because I have never done a meta-analysis also and a meta-synthesis also. So really I'll not be able to, but that's a point which I have taken it. I would definitely read and get back to it, because I'm really not aware. And if I am not aware, I would not disseminate anything which is halfway my brain. So that is one thing. Second is, someone has given a feedback regarding few research which they have done probably, that albumin can be the egg white which can be used for bed sore and all. That is again one good example. Definitely it's a nursing measure and we can use it, but I'm really not sure regarding the aseptic method of it and all. Let's find out. So that is one of the points which was there amongst the questions. So anything else apart of that?
No, ma'am.
Yes, ma'am.
Meta-analysis is analyzing one study, and meta-synthesis is for a group of studies.
But
actually, ma'am, there is difference in meta-synthesis. Mainly we go for qualitative study.
Yes.
Yeah, no. And meta-analysis mainly we based for quantitative.
Yes. No, even but you know the details about it. Even their statistics is completely different form.
Difference.
And you know, in meta-analysis and all, they do more of odds ratio and all. but whereas meta-synthesis and all, they do a different perspective completely. So that's why I told, maybe that's a half knowledge and I would not like to share whatever half knowledge I have. That's the thing. So let's all of us get that as an assignment and read it.
And one last thing I'd like to add here is that clinical audit is not a rocket science. Many people get scared and they're hesitant to do clinical audit, thinking that too much of documentation and report writing is required. No. And many places there are these fresher nurse educators who are masters, and they just replicate their research work in that format. Too much of statistical analysis and 10-20 pages, which is very, very complicated, which is not required at all. I had given a template. Just adhere to the template only in concise and very simple, clear language. It has to be written. Only basic statistical analysis has to be done. Your analysis has to be accurate and clear, and the entire report you should be able to complete within 3-4 pages maximum for clinical audit.
Ma'am, one more question is there, last question. How much percentage of literature's evidence from class 1 hierarchy will you consider as mandatory as a base for your review of literature on a certain topic?
See, as per review of literature, you have to do literature review up to exhaustion. So one thing is there that you can never reach exhaustion, but many of the theses and many of the topics which we see, they are not doing review of literature per se of the topic. It is like the entire, when you Google search also, say if you want to do on any bed sore, or say for example COPD also, so you are just writing that and whatever comes your way you will take it. No, it cannot be like that. It has to be particular relating to your topic, and you can go up to the exhaustion. There is no limitations that this much you can keep it or this much. You feel that it is exhaustive and you feel that yes, this much is required for your base of making a research, that's good enough. Books may give you another picture. I am talking about absolutely practical aspect. I'm not talking about theoretical at all. Right?
Yes. So moving to our last conclusion session, may I invite Professor Dr. Chitra Felicia, ma'am, member of CNR. She's principal of College of Nursing, Mother Teresa Postgraduate Institute and Research Institute of Health Science. She has experience in administration, education, and practice, and she's a strong organizational skill personality. It stands her quality, and she have achieved various achievements like Leadership Award, Educator Award. And to inspire the gathering with a takeaway message, may I invite Professor Dr. Felicia Chitra, member of Peer Review Committee, CNR.
No, can you hear me? Can you hear me?
Yes, ma'am, you can hear me.
Hello. Can you hear?
Yes.
Good evening and a pleasant evening to one and all gathered in this digital platform for sharing of this knowledge and views on today's topic. And I'm much privileged to send you all a note of gratitude for supporting CNRS by participating actively in this webinar. And I'm very much or immensely take pleasure to thank the speakers, both speakers, Ms. Bobby Ramesh and Ms. Deepa, for their valuable input in today's topic and the pain that they have taken to prepare and to enlighten each and every one of us with their practical knowledge and the things that they are implementing in their own area or field of nursing. And I'm really grateful to both the speakers for enlightening all the participants in this topic of today. And also, I would fail in my duty if I don't mention about Madam Uma Hande, because Madam, we are grateful to you. inspiring talk today and the experiences that you had throughout your service period. And it was very interesting to hear what you mean, the work you have done in those days and recently to bring about changes in documentation of nursing. Thank you very much, madam. And I would also like to thank all the participants without whom today's program wouldn't have been a successful one. And I also thank all the office bearers and members of CNRS for having thought of conducting such a webinar with carefully selected topic. And also I thank them for choosing the right personality or persons for delivering the topic today with their life experience and practical session. Thank you very much. Thank you one and all.
Thank you so much, ma'am, for your wonderful message. And once again, we express thanks to all who have joined us, and we assure that we will come again with another series of webinars or online courses. We are in pipeline to have some online courses for research and some other. And you are always most welcome to join CNRS also. For that, you may visit our website. And once again, we thanks to all the participants, all the speakers, and all the eminent personality, as we are running short of time, so we couldn't take feedback from our other senior experts, and definitely will keep opportunity to everyone later. And thanks to our ECHO India who has facilitated this webinar. And once again, thank you so much.
Thank you.
Regarding certificate, you may get within a week.